Welcome back to the Deep Dive. Today we are taking on a pretty massive mission. We are charting the landscape of internal chaos.
That's a good way to put it.
We're jumping right into endocrine and metabolic disorders. Specifically, what happens when the body's hormonal balance, the ultimate internal regulator, just goes completely sideways.
It's such a crucial area because the endocrine system, it runs the whole show through these really complex feedback loops.
Right.
And if you have too much of a hormone, we call it hyperfunction. Too little, well, that's hypofunction.
And that's our goal today, right? To pull apart those pairs.
Exactly. We want to extract the core mechanisms, the key distinctions, and what you need to do when these predictable crises actually hit.
Absolutely. This deep dive is all about giving you that instant clarity. We're looking at the most critical pairs of disorders affecting the pituitary, the thyroid, the adrenals.
And we'll wrap it all up with the pancreas, that ultimate fuel crisis.
The extremes of diabetes mellitus. Our focus is really on the why. Why these symptoms show up and what that tells us about how to treat them.
So let's just jump right in. We can start deep in the brain with the posterior pituitary.
Okay.
And we'll focus on the antidiuretic hormone, ADH. When you talk about ADH, you're really talking about the body's internal fluid wars.
SIADH versus diabetes insipidus.
You got it.
So SIADH, syndrome of inappropriate ADH. The name itself kind of suggests the hormone is doing something it really shouldn't be.
It is.
If ADH tells the kidneys to hold on to water, what is SIADH doing wrong?
It's just pouring water back into the system without any permission. You have a massive excess of ADH, and that causes the kidneys to reabsorb far, far too much water.
Okay, but here's the question. If they're retaining so much water, why doesn't that make their sodium levels go up? It feels like it should.
That's the paradox, isn't it? You'd think they'd just be bloated. But that massive water retention, it actually suppresses another really complex system.
The renin-angiotensin-aldosterone mechanism.
Exactly. And that suppression triggers the kidneys to just aggressively excrete sodium.
So the body is essentially drowning itself in water, and then to make it worse, it's actively dumping the salt.
That's it. So you get cellular edema cell swelling, which is incredibly dangerous in the brain, and what we call dilutional hyponatremia.
The sodium is low not because you're losing it, but because the blood is just too watery.
It's all dilution. So the critical contrast here is about concentration. The blood is dilute.
And the urine must be the opposite.
The urine is highly, highly concentrated. The kidneys are just locking down all that fluid. That contrast is your telltale sign: concentrated urine, dilute blood.
And what's fascinating here, and I think a really high-value insight for you listening, is what often causes this.
Yeah, because it's often not the pituitary itself.
Right, precisely. A lot of the time, it's a paraneoplastic syndrome. Certain cancers, especially small cell lung cancer, can just start secreting ADH all on their own.
The cancer itself is making the hormone.
Yep. Or you can see it with brain injuries, like meningitis, or even some common drugs like SSRIs.
So, given that the big risk is cell swelling in the brain, how do you treat this high water state without making things worse?
The primary management is pretty stark. It's fluid restriction.
Severe restriction.
We're talking maybe only 800 milliliters a day total.
And if the sodium is dangerously low, we might have to give hypertonic saline, something like 3% saline, but you have to go painfully slow.
Why the extreme caution there?
Because if you correct that sodium level too quickly, you literally pull the water out of the brain cells so fast that they shrivel.
Oh, wow.
It's a severe complication called cerebral osmotic demyelination. It can cause irreversible neurological damage. It is a very, very tightrope to walk.
Okay, so let's flip that coin completely. Diabetes insipidus or DI?
Sure.
If SIADH is the faucet stuck on, what's DI?
DI is the drain that just won't close. It's a state of severe water loss.
So these patients have profound polyuria.
Profound. They can excrete anywhere from 4 to 30 liters of urine in 24 hours.
30 liters, that's unbelievable.
It's a massive amount. And the severe dehydration that results leads directly to hypernatremia. Their blood gets really concentrated and sodium levels spike.
So conceptually, the labs are a perfect mirror image of SIADH.
They absolutely are. Their urine is incredibly dilute, like pure water, while their blood is highly concentrated. It's an internal drought.
And what's interesting is that the cause really dictates the treatment here, because there are two main types of DI.
Correct. You've got neurogenic DI, where the brain just isn't making enough ADH, maybe from head trauma or a tumor. The ADH faucet is just broken.
Okay.
And then there's nephrogenic DI.
Hmm.
In that case, the ADH is there, but the kidneys, the pipes, let's say, they just fail to respond. Sometimes that can be caused by drugs like lithium.
So if the faucet is broken, neurogenic DI, you just replace the hormone.
Yes, exactly. Hormone replacement with desmopressin, which is a synthetic vasopressin. That's the core treatment.
But the number one priority is water.
In all cases, yes. The immediate priority is just replacing the water they're losing, preferably by mouth, and just constantly monitoring their fluid balance. You're watching for that red flag urine output over 200 milliliters an hour for 2 hours straight.
Okay, let's move on to our second pair, the thyroid gland. This is the body's primary metabolic engine.
It really is.
And we're contrasting the system on total overdrive with the system in a complete stall.
So hyperthyroidism is the overdrive state. It's usually caused by Graves' disease, which is an autoimmune disorder.
And if your metabolism is running that high, you're just burning fuel like crazy.
You are. The symptoms are exactly what you'd expect. Heat intolerance, weight loss even with a good appetite, anxiety. You often see a goiter, that enlarged thyroid.
And then there's that one dramatic visual symptom that just immediately signals Graves' disease.
That would be exophthalmos.
The forward protrusion of the eyeballs.
Yeah. It's a very distressing symptom for patients. It's one of the clearest signs that the autoimmune process isn't just attacking the thyroid, but also the tissue behind the eyes. It needs its own specialized management.
And when you push this hyperstate to its absolute dangerous maximum, you get thyroid crisis.
Or thyroid storm. It is a devastating, life-threatening collapse. It's often triggered by some kind of sudden stress on the body.
Like an infection or surgery.
Exactly. And when the storm hits, the patient becomes hyperthermic. We're talking very high fevers, over 102 Fahrenheit, extreme tachycardia, and just profound confusion and agitation. The whole body is literally racing itself to death.
Wow. And treatment can be really tough. Antithyroid drugs or radioactive iodine.
Which requires serious isolation precautions. The patient becomes temporarily radioactive.
Or surgery, a thyroidectomy. And if they go for surgery, we have to think about what's right next door, anatomically.
You do. When you surgically remove the thyroid, you are right next to the parathyroid glands. And if you damage those,
You risk causing hypocalcemia, critically low calcium.
and that low calcium is an emergency. It presents as what we call tetany.
Right. And the earliest signs are pretty subtle, aren't they?
They are, usually just some numbness or tingling around the mouth, maybe the fingertips. But it can progress really quickly to severe muscle twitching and cramps. The surgical team has to be ready to replace that calcium immediately if those signs appear.
Okay, now let's pivot to the opposite extreme. Hypothyroidism, the metabolic stall.
Right, insufficient thyroid hormone. It can almost mimic the aging process, but in fast forward.
The symptoms are the complete antithesis of hyperthyroidism.
Everything just...
Those
Patients have this profound lethargy, weight gain that's so hard to lose, bradycardia, cold intolerance, coarse, dry skin and hair. They are running on pilot light.
and their ultimate crash state.
That would be myxedema coma. It's a true medical emergency. It's defined by this severe metabolic slowdown,
So, hypothermia, severe hypoglycemia.
cardiovascular collapse. And a signature physical sign is this non-pitting edema. It often makes the face and the tongue look extremely puffy.
And treatment is lifelong hormone replacement. It sounds simple, but getting patients to take levothyroxine correctly is so crucial.
It really is. For it to be absorbed properly, levothyroxine has to be taken on an empty stomach. The best time is about an hour before breakfast.
And they have to be monitored right, because
Yep.
you could overshoot.
You can. The goal is to correct the hypo state, but if the dose is too high, you can accidentally push them right into a hyperthyroid state. It's a balancing act.
Let's shift gears now pretty dramatically to the adrenal cortex. We're focusing on cortisol, the body's main stress regulator.
And this pair, Cushing's syndrome and Addison's disease, these are probably the most visually distinct disorders we'll talk about today.
Cushing's syndrome, that's excessive cortisol.
And you can almost diagnose this one from across the room. The physical signs are so classic and dramatic.
You have truncal obesity, where fat gathers around the torso.
The classic moon facies, that round red face, and the buffalo hump, which is that fat pad that forms on the upper back.
These patients also get very thin, fragile skin that bruises easily, plus high blood sugar and sodium.
That's right. Cortisol is catabolic, so it breaks things down, which explains the skin fragility. But here's where it gets really interesting. While Cushing's can be caused by tumors, the most common cause is actually iatrogenic.
Iatrogenic. So you're saying the most common cause of this incredibly visible, dramatic syndrome is something we prescribed.
Yes, it's the long-term, high-dose use of glucocorticoid medications, steroids.
The ones used for common things like asthma or severe allergies.
Exactly. It just highlights the double-edged sword of these powerful anti-inflammatory drugs. Now, if the cause is a tumor, treatment is usually surgical removal or drugs that suppress cortisol production.
Okay, now for the total deficiency. Addison's disease, insufficient cortisol, and also aldosterone.
With Addison's, everything just collapses. The aldosterone deficiency leads to severe fluid loss
So you get profound hypotension, low sodium hyponatremia.
and critically high potassium hyperkalemia and significant weight loss.
And the most unique physical sign of Addison's is that hyperpigmentation of the skin. Patients look like they have a deep, sort of uneven tan.
Yeah.
Why does that happen if they're lacking cortisol?
That's a fantastic question. The pituitary gland is trying desperately to stimulate the failing adrenal gland, so it pumps out massive amounts of a hormone called ACTH.
Okay.
Well, the precursor molecule for ACTH is also a precursor for MSH, which is melanocyte-stimulating hormone.
Ah, so in trying to boost cortisol, the body accidentally boosts skin pigmentation at the same time.
It's a fascinating evolutionary quirk,
And the ultimate collapse here is the Addisonian crisis.
which is a fast, deadly response. It can be triggered by sudden stress or, and this is critical, the abrupt withdrawal of necessary steroid medication.
That leads to shock and circulatory collapse.
It does. Treatment is immediate and aggressive fluid resuscitation and hormone replacement. Hydrocortisone for the cortisol, fludrocortisone for the mineralocorticoids. This is where patient education is it's everything. Addison's patients can never stop their medication abruptly.
Okay, our final system, the pancreas. And the critical distinction between the two major hyperglycemic emergencies of diabetes mellitus. Let's call it the fuel economy crash.
I like that. DKA versus HHS. This is a life-saving distinction to know.
Let's start with diabetic ketoacidosis, DKA. This is typical for type 1 diabetes.
Right, where there's an absolute lack of insulin. And without insulin, glucose can't get into the cells for fuel, so the body has to turn to breaking down fat.
And the result of burning all that fat for fuel is what defines DKA.
Exactly. Fat breakdown produces ketones, and ketones are acidic. So the hallmarks of DKA are glucose levels usually above 250, the definitive presence of ketones in the blood and urine,
And a state of metabolic acidosis.
which the body tries desperately to compensate for through breathing.
Right, we call that Kussmaul respirations.
That's that deep, rapid, labored breathing. The patient is literally trying to blow off the excess acid as carbon dioxide to raise their pH. And this often comes with that characteristic fruity acetone breath odor from the ketones. DKA comes on fast, usually over hours.
Okay, then we have hyperosmolar, hyperglycemic state, HHS, usually seen in type 2 diabetes. The picture here is one of extreme dehydration.
With HHS, the hyperglycemia is just so much worse. Glucose levels can soar past 600, causing this profound hyperosmolarity, pulling massive amounts of water out of the cells.
But there's a critical distinction.
A critical one. There is usually just enough insulin still present to prevent the full-scale breakdown of fat.
Yeah.
Meaning there are NO ketones and NO acidosis. The primary problem is the severe dehydration and hyperosmolarity, not the acid-base balance. And the onset is much more gradual. It can develop over days or even weeks.
But regardless of whether the patient is in DKA or HHS, the immediate management priorities are identical, aren't they?
They absolutely are. Priority number one is aggressive fluid replacement, usually starting with normal saline to fix that severe dehydration.
Followed by regular insulin to bring the glucose down.
And critically, you have to monitor potassium levels with an ECG. Because as you push insulin into the body, potassium shifts rapidly back into the cells, and that can cause really dangerous cardiac arrhythmias.
We have managed to cover the absolute opposite poles of hormonal chaos today across 4 different systems. You've seen how these disorders, which seem so varied, are all linked by one fundamental theme.
A severe imbalance. It's always too much or too little of a vital chemical.
And you now have the tools to recognize those critical conceptual distinctions.
Right. The difference between dilute versus concentrated labs in those pituitary wars, the presence or absence of ketones in a glucose crisis, and even why one stress disorder causes dark skin while the other one causes thin skin.
It shifts the knowledge from just rote memorization to a more strategic understanding.
It does.
So, given that Addison's disease, that system failure, can be triggered by the sudden, maybe seemingly innocent, stopping of steroid medications used for common problems like asthma or joint pain, what systems in your own life might be relying on a subtle chemical balance you don't even realize you're managing? Think about that unseen maintenance your body performs every single second, and we'll catch you on the next deep dive.